Hello, I'm Dr. David Greer from the Boston University, and I'm the editor-in-chief for Neurocritical Care on Call. Our chapter is on hypoxic-ischemic injury, which I did with multiple great collaborators. I would like to tell you that this is still a big and bad disease, and we have great headway to be made in our efforts in neurocritical care. So hopefully this update will be very timely and very useful for you. Just to review some basic facts, cardiac arrest is a common problem in the US and worldwide. There are over 500,000 cardiac arrests per year in the US, and about 2 out of 3, or 2/3 of them, occur out of hospital. About 10% of out-of-hospital cardiac arrest patients survive to discharge, and many of them have long-term disability. The survival rates are higher with shockable rhythms such as VT or VF, although patients with HIE due to asystole or PEA can still make good recoveries. And I like to say that the brain doesn't really care why it's not getting enough blood flow and oxygen. It just wants it back and will be injured regardless of the rhythm. And so don't give up on a patient who's just simply had an asystolic or PEA arrest. The outcome scales that we use to evaluate patients after cardiac arrest survival include most typically the Glasgow-Pittsburgh CPC score, with CPC of 1 to 2 indicating a good outcome. Although there are patients with a CPC 2 or even 1 who have significant neuropsychological or cognitive impairments that affect their day-to-day lives and often impair their ability to even get back to work or function independently. So just because somebody achieves a good scale on a research scale, they may be left still with a very significant disability, and that's worth keeping in mind. Many of the more modern studies have been looking at neuropsychological outcomes in particular to see if we can be more specific about the impact of cardiac arrest on these patients and what it truly means to them and their families from a cognitive standpoint. When we talk about the pathophysiology of HIE, we think about initial and secondary injury. There's the initial injury from the cardiac arrest itself, and then there's ongoing injury that happens in the minutes to hours and maybe even days after the initial insult. And in some ways that's great because it gives us an opportunity to potentially use therapeutics to improve outcomes in that time window, including things like therapeutic hypothermia, which is well known to everyone, but also potentially other less used neuroprotective strategies which may be able to work within this window. The secondary injury occurs secondary to a poor reflow phenomenon, and this happens due to multiple things. There's basically a microcirculation clogging effect where you have endothelial cell swelling, you have increased white blood cell endothelial cell interactions, and you get DIC on the micro level. All of these things can affect the microcirculation and cause ongoing injury. And there's also delayed apoptosis, and because this happens in a delayed fashion, you may not see very much on an early diffusion-weighted image after cardiac arrest as opposed to an ischemic stroke, and that tells us that there is likely a very good window in which we can use therapeutics to treat this delayed process, a delayed apoptosis, perhaps the microcirculation sludging that's occurring. And so in a lot of ways, that's good news that you have a window that you may not have in other diseases. The resuscitation efforts obviously start with CPR, and having effective CPR and rapid resuscitation are integral to avoiding severe cerebral injury. As a general rule, the longer somebody codes for, the worse their circulation will be and the worse the brain injury. Recognizing the etiology of the cardiac arrest is key to resuscitation. There are advanced methods such as ECMO that are revolutionizing the field and creating more survivors than previously thought possible. And these are patients who may go on to have excellent outcomes as well. So that's an intra-arrest or peri-arrest method that may be extremely beneficial. The post-cardiac arrest syndrome, or PCAS, is the next stage after ROSC, which is return of spontaneous circulation, and it's crucial to improving recovery. Early coronary reperfusion is the gold standard, as maintenance of adequate systemic blood pressure is integral to maintaining cerebral perfusion. So in other words, you need to get the vessels open so that they can adequately have the heart pump and that there is excellent forward flow into the brain. Targeted temperature management has become the mainstay of treatment, and recent studies have suggested that the target temperature can be anywhere between 32 and 36 degrees. In fact, there's great debate as to which works better. There's even debate as to whether either one is necessary, or maybe 37 is the right temperature. And that's the subject of the TTM2 study comparing 37 degrees to 33 degrees. Regardless, for now, the target temperature is anywhere between 32 and 36 degrees, and many hospitals do it differently, even within their own hospital. The duration of cooling is typically 24 hours, although that's also under debate. There is some feeling that 48 hours might be more effective, and thus that's the subject of a different study as well, comparing 24 and 48 hours. We do know that starting cooling earlier is always better. There is a benefit seen in human studies up to 6 hours, but certainly the earlier someone gets cooled, the better they typically do, and the better the chances for survival and good outcome. There are multiple effects of hypothermia that need to be borne in mind, including cardiac effects, which include bradycardia as well as other potential dysrhythmias, endocrine problems, particularly hyperglycemia, metabolic problems, including hypokalemia and hypocarbia. There's impaired drug clearance, and there's hematological abnormalities, including coagulopathy, immunosuppression, and there's also acidosis that can occur with hypothermia. Hypothermia affects drug metabolism by impacting the cytochrome P450 enzymes. The metabolism of medications used in critical care can be impaired by this, including propofol, phenytoin, clopidogrel, metoprolol, dexmedetomidine, amiodarone, some paralytics, and other medications. The management during the cooling period can be challenging. Many prefer to paralyze and sedate the patient in order to prevent shivering. This may be less necessary when going for a higher target temperature, as the shivering can be managed by using such combinations as counterwarming, magnesium, buspirone, dexmedetomidine, and meperidine. Shivering can rapidly generate heat and induce a highly catabolic state, and thus it should be detected and treated aggressively. Seizures are common in the post-cardiac arrest period and should be aggressively detected and treated as well. The incidence of seizures is up to 30% and may be clinically overt or subclinical or non-convulsive. Benzodiazepines are considered first-line agents, but more aggressive means may be necessary, including the use of levetiracetam, phenytoin, or even continuous drips to control frequent seizures or status epilepticus. Ventilation should take care to avoid hyperoxygenation and hyperventilation. Most patients are inadvertently hyperventilated, leading to a reduction in CO2, which could cause cerebral vasoconstriction, which in this setting could worsen brain ischemia and outcomes. So this must be monitored and appropriately addressed. And the changes in PCO2 should take into account the patient's temperature. Switching now to Neuro Prognostication, this is a key part of the neurointensivist job. Multiple tools can be used to prognosticate neurologically after cardiac arrest, and care must be taken to avoid or eliminate confounding and give the patient enough time to recover, as probably one of the biggest biases in all studies is the self-fulfilling prophecy due to withdrawal of life-sustaining therapy prior to a patient showing that they might wake up, and not just wake up, but have a good recovery. Confounding can consist of delayed drug metabolism, particularly sedatives. This is especially true in the setting of hypothermia, as well as other concomitant end organ injury leading to uremia or hyperammonemia, which could further cloud the picture. The patient should be maximized, of course, to allow them to show their best examination and help guide the prognostication most accurately. The clinical examination remains central and paramount, with particular attention to pupillary and corneal reflexes, as these best correlate with outcome. If you have truly absent pupillary and corneal reflexes tested at the appropriate time, the likelihood of good recovery is extremely poor. The proper timing is important, and testing should be delayed until at least 72 hours post-arrest, or at least 72 hours post-complete rewarming if they got cooled. The testing of pupils requires good technique. Using a swinging flashlight is not a great technique. Using a magnifying glass is an improvement, and many people now are using pupillometers to see if there's something that your naked eye cannot appreciate, as this is a matter of life and death. Corneal reflex testing, similarly, many people don't test this appropriately. The proper place to test on the cornea is actually adjacent to the iris, where the cornea is, and not out on the conjunctiva, where there may be decreased sensitivity. I also advocate pressing with a cotton tip applicator to make sure that there's enough of a stimulus rather than just a quick saline squirt. Note that the motor exam is no longer valid to say that the patient is going to have a good or a poor outcome, but may be used as a screening tool. The presence of myoclonic status epilepticus previously was felt to be a poor prognostic sign, but there are now multiple reports of patients who are making good outcomes despite having myoclonic status epilepticus. If you see myoclonic status epilepticus, you don't know whether the patient is actually seizing or not, and thus getting an EEG every time is very important. Sometimes you need to paralyze the patient to see what's going on in the EEG below the myoclonus because it can cause a lot of EMG artifact. And again, if you see seizures with myoclonic status, treat them. Electrophysiology otherwise can be helpful in evaluating patients post-cardiac arrest, including SSEP and EEG. SSEP typically uses median nerve stimulation, looking for the cortical potential contralateral to the stimulation. The cortical potential is called the N20 potential, and if they're absent bilaterally post-cardiac arrest, that's been correlated with poor outcome. However, again, you need to let enough time pass because there can be false positives early on, and thus testing should be delayed for at least 48 hours post-arrest, or again, 48 hours post-complete rewarming if the patient gets cooled. An EEG, again, is helpful. A spot EEG can be misleading. The EEG can often improve after a cardiac arrest, with initially malignant-looking rhythms improving into more productive rhythms that may lead to a good outcome. So continuous or serial EEG at the very least is important. Again, if you see seizures, it's important to treat them. Sometimes the EEG gets worse, and thus that can be a sign of ongoing injury or brain swelling. The EEG rhythms that have been associated with poor outcome include suppression, discontinuous background, burst suppression, and lack of reactivity. Always a reactive background is better than a non-reactive background on EEG. And again, the EEG can evolve, so doing it seriously is important. Chemical biomarkers that have been used include most traditionally neuron-specific enolase. There are lots of false positives with NSE, and thus it's important to get serial values, and perhaps looking at the trend over time is much more important than looking or relying on any single value. There are other more promising chemical biomarkers that are coming out, including tau and neurofilament. They're not quite ready for prime time, but the initial data looks like they are much more specific for brain injury, so stay tuned. Although not validated for use, neuroimaging can be very helpful, and both CT and MRI have their role. A CT on the day of admission or just in the peri-arrest period can be helpful for ruling out a CNS cause for the arrest, but it's typically not helpful for prognostication. For prognostication purposes, we recommend getting a CT 2 to 3 days post-arrest or post-complete rewarming. And if that's normal or close to normal, getting an MRI day 3 to 5 post-arrest or post-complete rewarming again, as the MRI will be a more sensitive modality. In summary, probably the most important thing that we can tell you is to use a multimodal approach with every patient, that all of your data should jibe with one another, and if something doesn't make sense or the neuroimaging doesn't match what's going on with the patient clinically, give the patient more time. Also take into account confounding, that a patient can have significant end organ injury that's causing there to be confounding of the exam or ongoing sedation, and so these things have to be eliminated before giving a final prognosis. How much time do we give? I advocate for at least 2 weeks in patients who are uncertain about the prognosis. Hopefully you get some signal by then as to whether they're making a recovery or not, and it's also the time when we need to start thinking about whether they need a tracheostomy to have more prolonged care. So I hope that you enjoy the chapter on hypoxic ischemic injury, and we look forward to hearing from you soon.